So we are going to learn about the rupture of the uterus. So here you can see it is a rare complication, but if it happens it is very dangerous, and the wall of the uterine wall is getting separated. Either the fetus may be expulsed outside or it can be inside itself. During the rupture, maybe the fetus is within the uterus, or maybe the fetus is already expulsion is taken place. But anyway, the both mother and the fetus life is threatened. So it can happen either during pregnancy or in the late stages of labor. Either it can happen during the labor time or during the pregnancy period, especially the late stages of the pregnancy period. So when we say about the types, you can see that the uterus is having 3 layers. So inner layer endometrium, then myometrium, then perimetrium. Then you have the visceral peritoneal and also then parietal peritoneum. In between you have the peritoneal cavity. So this is the fetus. So what exactly happened during this dehiscence? Dehiscence is incomplete rupture. So in incomplete rupture, what happens is the visceral peritoneum is intact, but the layers will be cut. The layers will be torn. Rupture of all the layers of this uterus, so that the fetus is within the uterine cavity. But if complete rupture happens, that means the 3 layers of the uterus, also the visceral peritoneum, then what happens? This contents in the uterus will be escaping into the peritoneal cavity, so the fetus can reach here. Now you look into this picture. So here you can see just a herniation. So that means it is just incomplete rupture, but in complete rupture the fetus may go into the peritoneal cavity. Now you can see. So first of all we have to know what are the reasons for this. As I have told, the rupture can occur either during pregnancy or during labor. So first of all we will study what is happening during pregnancy, what may be the problem. So you imagine a pregnant lady. Okay, so what are the reasons why uterus can rupture during this pregnancy? So the reasons can be like, either it can be due to any trauma or it can be spontaneous, or already there may be some kind of an injury in the uterus. So that means previously she had a CS. So the scar can get ruptured. Now it can be due to trauma. So it can be either a blunt trauma or an accident. Okay, so it can be a trauma or it can be spontaneous. Spontaneous reasons can be like placenta percreta. So we have to know what is placenta percreta. So you can see in a uterus, placenta Accreta, increta, percreta. There are 3 types. So when the placenta is attaching too deep into the uterine wall, then that is accreta. So in accreta it is again to the endometrium, but it is too deep. In creta it has gone into the muscle, that is myometrium. In the percreta it has gone till perimetrium. Sometimes nearby organs like urinary bladder also. Now suppose if the problem was during labor, what are the reasons that can happen? So now we are saying about what happens in labor. So in labor it can be a trauma, or it can be spontaneous, or there may be some pre-existing injury. So as we have said, she was having previously a CS, or previously some curettage was done, or placenta percreta. So all these things, previously some kind of intervention is already done in the uterus in such a way that her uterus has got a scar. Some kind of a scar is there in the uterus. So that may be the reason. That scar, especially what happens is, when it becomes a scar, it is just a fibrous tissue that can easily get ruptured. Now in case of a trauma, what are the things that can happen here? So here an intern or a doctor is doing some interventions. Either it can be for taking the baby, at that time it was a breech extraction, or it can be during forceps delivery, or the manual removal of placenta, or it can be internal podalic version. So it can be either during the taking the baby or taking the placenta, that is manual removal of placenta. Taking the baby means that is breech extraction or difficult forceps, like that. Now in case of spontaneous rupture, here you can see the spontaneous. So that may be because of we know there will be giving IV, oxytocin and all. So the IV infusion can be the reason. Injudicious use of oxytocin, prostaglandin, or sometimes she already have many children. She is a multiparous woman. All these are her children. So that all this time after delivery, the uterine tissue has got some fibrosis that can easily get ruptured, or it can be because of the overstretching of lower segment as in obstructed labor. Now we have already seen what are the risk factors. So especially we have told cesarean CS is an important risk factor, of which classical has got more risk than LS-CS. So if it was a classical section CS, will get more risk of rupturing. Or previously, if she had the same incident, previously she got a rupture, uterine rupture, or prior preterm cesarean delivery. So in traumatic rupture, usually in the uterus, the rupture starts from the cervix from the cervix or the lower segment, then it goes and involves the broad ligament and all. In spontaneous rupture, usually what happens is it can be a longitudinal or oblique tear in the lower segment, and it can go down to the vagina or can go up to bladder. So you can see when these vessels are also involved, intra-abdominal hemorrhage. Now let us see how to monitor. So we have to monitor the mom. We have to monitor the baby. So you have to look for the heart rate of the mom. Maternal tachycardia will be there. In the fetus also there will be some heart abnormality. And abdomen, you have to ask if there is any pain or either tenderness in the scar, or in the vaginal examination you will get vaginal bleeding. So how can you diagnose? As I have told right now, there will be tachycardia, the tachypnea, fever, signs of dehydration, and you can get a Bandel's ring. So the upper uterine segment will be retracted, lower will be dilated, so that separation you can identify there will be a ring, and that is Bandel's ring. Normally the abdomen is like this, but here one area has got retracted, other area is distended. So you can, how can you know there is an incomplete rupture? That means a dehiscence. So when there is dehiscence, the maternal tachycardia, as I have said, all these features will be there. Plus, as I told, tenderness, vaginal bleeding, tachycardia, uterine contractions will be present. And sometime in the fetus there can be fetal tachycardia, variable deceleration, or sometimes the fetal bradycardia can also happen. Now in case of a rupture, as I have said above in the before, when there was dehiscence also there was tachycardia, maternal tachycardia, vaginal bleeding, and there was tenderness. So everything will be severe in here. You can see the severe pain in the lower abdomen. Later the pain will be stopped. There will be no pain. Tachycardia will be so high that patient can go into shock. Vaginal bleeding can be profuse. And look at this point, there is no uterine contraction. And the uterine contour is low. So up to that patient will be uncomfortable, but when complete rupture has taken place, patient will be staying very comfortable on that table. So we might think, oh, everything is okay, but it's not okay. It's got more dangerous inside. And uterine contour is low. So since the uterus has ruptured, as I have said before, the uterus inside you have the fetus, isn't it? Fetus inside. So you have the peritoneal layer and all. Now what here exactly happened is the rupture. So that in the abdomen, initially in the abdomen you have the peritoneum, the uterus, within which fetus, but here you can palpate very easily, fetus has come out. So you can feel very easily right than the other one, because here everything has got ruptured and the fetus come outside. Profuse hematuria. So what happens when you look into the vagina? Loss of station of fetal head, because in the vagina here, okay, fetus can be lying anyway, but let us actually draw a cephalic presentation. Okay, so like this, when you look into the vagina, what you get, you can feel the fetal head. But when you look into here, no, there is loss of station of fetal head. So how can you manage? Management can be either conservative. So here, whatever rupture has occurred, you have to repair it. Either you can ligate the tube, either you can avoid ligation of this tube. Anyway, you have to rupture that part. Or in case of bleeding, you can ligate the artery, internal iliac artery. Any other organs like bladder have ruptured, again you repair that. Now, immediately, what exactly? So all those things you have to do, but what you have to do first of all is you have to take her for the CS. You should not expect for her to go for a vaginal delivery. You can go for laparotomy, immediate laparotomy and CS. So actually here it's not stop VBAC, stop TOLAC. You have kept the patient for trial of labor after cesarean. You have kept the lady for a vaginal delivery, though she had a CS, but you found that she is not fit. So you have to take her for CS. So in all patients, when in all the people who have got CS, you will not, in the next pregnancy, you will not go for a vaginal delivery. Only if these patients are fit, you go for vaginal. Otherwise, you directly go for CS. Here we have tried for a vaginal, but we found no, so we go for CS. If she was a case of TOLAC, then again, do not think again, you take her for CS. We are working for the benefit of patient. Here you can see either in case of a profuse hemorrhage, blood products should be given, blood transfusion. Also the fluid replacement, when the baby is taken out, you have to resuscitate the baby. So as we know that it's not ideal in every case to remove the uterus, because the patient may be desired for future childbearing. In that case, we have to keep the uterus in favor of the patient. I mean, in such a way that it does not affect the health of the patient. So that is conservative management. You do the repair only such a way you keep the uterus there itself. So only if the tear has no great extension, it's only a small rupture in that case, or a small hemorrhage, you can go for that. Otherwise, you have to go for hysterectomy, subtotal or total. And the complications, so whenever whatever things happening here, the ruptures, all this catastrophe happening in an abdomen, so the nearby organs can be damaged, infection can occur, or it can be a very big hemorrhage or DIC or amniotic fluid embolus. So you have to know what are the differential diagnosis like abruptio placenta or amniotic fluid embolism, like that. In order to prevent that, you have to give good antenatal care. You have to diagnose if it is a case of cephalopelvic disproportion or a malpresentation, like that, and you have to select the case. You have to know whether she is fit for a vaginal delivery. Otherwise, if she is not, then you take her for CS. And from our part, we should not give injudicious use of oxytocin, prostaglandin and all, or no avoidance of intrauterine manipulations. In case if tubal ligation was not done, then there is again a risk of rupture in the subsequent pregnancy. Okay. So when a lady have got uterine rupture in the previous pregnancy, it is better that taking her for a CS rather than getting her for the vaginal delivery, because we know it is a great risk factor. So that is about, and you have to monitor the lady and the child, the heart sounds, the partogram, cardiotocography, all these are important. Okay.